So Dr. Ma is not only a great football doctor, but also really an expert in cartilage. And so he's going to speak to us this morning about cartilage injuries. Have we figured that one out yet? So please join me in welcoming Dr. Ben Ma.
Thank you over here. So yeah, Lincoln Mustangs. Yeah, I've been taking care of the team for 16 years right now. So we're pretty fortunate. We actually make the state finals this afternoon. So we're pretty exciting. So maybe I'll come back, with this big paper ring on. I can make some fake ring over there. That'd be great over there. So thank you. So thanks, Colin, for putting on a great course. And I think see some familiar faces in the audience too. So we talk a little bit about cartilage injuries and. Have we figured that one out yet over there? So these are some of my disclosures. Some of these are actually coming from the research and also support they have in terms of for my group. So this is what I get at clinic all the time. I don't want to get a knee replacement, doc. I don't want it. And I know that Dr. Ward gave you a great talk about how great knee replacements are, but my patient comes and say, I don't want to get a knee replacement. Have you figured out how to grow cartilage, how to actually help me out over there? So we're going to focus on talk about surgical treatment for cartilage injuries and also, maybe some roles of what injections could do also, okay? So just a question over here, kind of, frame the problem over here. So I have a small cartilage injury, about 1 centimeter, which is kind of like your size of your, kind of ring finger nails over there, but it's pretty deep cartilage injury, involves the bone. What is the best, way to take care of it? So these are, options over here. Clean up surgery, right? I think orthopedic surgeons are great doing those, cleaning up surgery. Microfracture, you may have heard of that. We'll talk about that later on. Mosaicplasty, which sounds a little weird, what their name is. Osteochondral allograft. Allograft means taking it from someone else. Is it growing cells? Did we figure that out yet? Or is it knee replacement? So let's ask that question and see what you guys see the answer here. Yeah. All right, this is great over here. This sets the stage over here. Lots of people like clean-up surgery. And also, my patient uses, the great, can you just shampoo my knee? And it took me about 5 seconds. People were like, what do you mean by that? Okay, cleaning up the knee. Okay, all right. So why is cartilage so hard to take care of it? So articular cartilage, which is the covering of the bones, a type 2 collagen. They make up like chondroitin sulfate. They're highly organized. When these are actually histology slides of the cartilage over there, they're very, very, small cells, but lots of extracellular matrix over there. There's not a lot of blood supply. There's actually no blood supply going to cartilage. So when cartilage get injured, they can't repair themselves very well. They're also immunoprivileged, means that there's no cells that can help, kind of fight infection. That's why when your infection goes into the knee, there's very big problems over them. The other thing about cartilage injuries is that not all injuries are symptomatic. Sometimes these are big, big lesions and people actually know symptoms, or they have a small 1 centimeter lesion, size of your little index fingernail that could be swelling. So it's kind of hard to kind of really manage these patients and actually guide them. Some are symptomatic, some are not. They usually present with swelling, plus minus pain, depends on how much, or how big the lesion is. Occasionally may have some catching, there's a loose fragment over there. Non-operative treatment, over there, I think most of you guys are familiar in terms of activity modifications. Just don't run the marathon. It's okay. Walk it, okay? So, or go on a bike, or watch somebody do the marathon. It's okay also. Bracing, you actually do some unloading bracing, take some stress off the knees. Injection, there are different types of injections you could do over there. We'll go through a little bit of that at the end. Most of you guys know how to do steroid injection, right, on the joints? Show of hands. Some over there. How many of you guys do a hyaluronic acid? Some over there. Well, how about PRP? Ooh, stem cells. No stem cells? Oh, I think we're behind the, we're kind of behind the tides over here. We need to get on the stem cell business around here. So let's do that. So we're talking about surgical treatments and what are different, treatments available right now. So, I think as a surgeon, people always have to, why can't you guys fix it over there? So there are palliative treatment, which is kind of cleaning up the knee. There's reparative type process, which is you try to stimulate some healing. The restorative means just kind of moving things around to restore the cartilage. or realignment, which is kind of realigning the joint over there. So I use this analogy all the time. So almost, the cartilage is almost your treads on your tires. So you went through the pothole. I know it was a bad, 101 North over there. There's a big pothole. You went through, pothole, and then you damage your tires. Well, fix that tire. Well, it depends how bad the tire's injured, right? You blew your tires completely blown out. The wheels are bent. Well, knee replacement. That's what needs to be done. Well, it's just a little pothole and actually have a little dent on the side, but you may be able to patch it or maybe smoothen it. So it depends on what the injury is. But a lot of times people actually don't realize, their problem is not just a little cut, it's actually pretty worn out, and some of the treatment are not available for them. So in terms of palliative treatment, these are the clean out surgery. So that we go in arthroscopically, you can take some of the loose cartilage away. We actually lavage the joint, take some of the inflamed tissue away. You can mechanically remove these cartilage. You can actually curette these cartilage out also, and maybe cut it out mechanically and also with heat also. Data are not that good over there. So I think most of you guys may have heard about this, a study that people say, well, these arthroscopic surgeries are no different than sham operation over there. Lavaging or debridement for basic arthritis is no difference in actually bringing the patient in and make 2 cuts on the knee and actually pretend you do something. So clean out surgery actually not really indicated anymore. Now, this is very different from dealing with mechanical problems. I have a meniscus torn and really, flip into the joint. It's, painful. Those could be, still successfully treated with arthroscopic surgery. But if I have a worn out knee, I'll just bring you in the operating room. There's a clean out the knee or shampooing the knee. Not a very good operation anymore. So when you have patients actually go to have to clean up the knee over there, think twice about that over there for these patients. Well, can't you stimulate some healing, doc? I'm a human being over there. I can heal the skin cuts over there. Why can't I heal the cartilage over there? So microfracture, what the treatment that we could do, in which we put little pokos in the knee, to allow the blood to come out into the joint, actually form a blood clot. And when the blood clot get organized, you almost see form like a scar over the exposed cartilage. So this is a patient of mine over there. We'll put a little poco in the knee. Now, everything's magnified 5 times, okay? We're not bleeding this patient to death. This is not the old bleeding surgery over there, it's pretty magnified over there. So the idea is that you have bone marrow cells that go into the area, hoping you can form some cartilage over there. But the body's not so smart. It means that the blood will form, but it doesn't form normal cartilage. It forms what we call fibrocartilage. So the way I tell people is almost like a scar that covers the bone, but does not have the same kind of structure and toughness in articular cartilage. So microfracture has been used for a long period of time right now. I think about 20 years. Dick Stedman's actually one of the forefathers that educated us how to do it. He actually used to practice at Tahoe and actually retired at Vail. So there, patients actually have good reported outcomes, with long-term outcomes over there. There are also people actually able to go back to play at a high level in the NFL. But, it depends on what sport they do. Football players seem to be tougher. They actually, recover well from the surgery. But basketball players not so well. So only about, 38% or 40% people actually have these, microfracture, procedure able to go back to play. In general, I tell people microfracture because the nature of the operation form the scar. It's good for a short period of time, but the scar just doesn't keep up with the rigor of the knee and tends to break down. So long-term results are not as good. They're kind of temporary for a shorter period of time. And also, the smaller the lesion, it works better. So a lot of people actually still undergo more the further surgery if they actually undergo microfracture. So if you can't really resurface the cartilage. If you actually can't just stimulate cartilage in the healing, can you resurface it over there? So there are different ways that we could resurface cartilage. It means that hey, I have an area that actually lost some cartilage. Can I actually build up the cartilage somehow instead of getting the patient to kind of heal themselves? So one of the things we'll call Mosaicplasty. The other thing we could do is an Allograft. Or, it's 2019 right now, right? Can you grow some cells that can put in there? So that's something we're actually looking into that also. So we'll go through that a little bit over there. So these are different treatment over there. So one of the things that we could do is called Mosaicplasty. Mosaicplasty is an operation where we basically take little plugs of cartilage from somewhere else in the body and move it over to the areas that's injured. So the analogy I have is almost like when you look in a room over there, the towels in the the carpet in the middle of the room is all scratched up over here as well. Let me cut up a little, kind of corner of the, the carpet from the corner, bring it over there, patch it up for you. So you're robbing Peter and pay Paul. But when you actually rob Peter, you take, like normal cartilage, to bring it over there. You bring it, plugs from one, side to the other. So these are actually, operation we actually, usually do it in a single stage. We bring the patient in. We make a small incision where we take cartilage from the areas of the knee that's not so important and bring it to the area that actually need it. So basically, you're robbing Peter and Paul over there. But Peter and Paul is the same person, right? So you're taking it from your own person over there. So your own need to bring it over there. So there's no someone else to take it from, at this point. So you're trading one area of problem to another area. So you usually, take it, from the non-weight bearing joint of the knee, which is the front part of the knee, to the area where you're standing on. So these are little plugs. The reason why we call it Mosaicplasty, because when you look at this little, surgery we do over there, they're little plugs over there. They don't line up properly, right? They're only little matchsticks over there. They're not really smooth. So if it's really, really good operation, would be like a, flat surface plasty. This is not. This is Mosaicplasty. It means they're a little bit rough, and tough with this. The body needs to still heal those edges over there. So they're good. So you're basically replacing cartilage with cartilage. But the results are good with for active patients over there. People are able to go back to sports, especially for deeper lesions involving the bone. These are great because you actually take the plugs of cartilage and the bone involved in also. But you could only take so much, right? If you have a room this big over here, the middle part of the carpet is completely worn out. Well, how many little patches you could take on the side to, cover that area? So you can only cover certain sizes lesion, big lesion, like say 2 to 3 centimeters. You cannot, cover them. But it's a good operation in general. Okay. The other thing you could do is, well, you know what? If, my room, my carpet in my room get worn out, can I just go somewhere else? Let me go to like Marriott. Let me actually take their carpet over there and kind of cover it over there. Well, that's what could do it also. So it's got allograft, which actually basically taking cartilage from someone else. These are usually graft that people pass away. We harvest a graft over there, and actually tissue bank allow them to kind of prepare the graft, for us, and they would bring this cartilage to us, and we actually implant cartilage from someone else into the defect. So this is actually a bigger lesion, about 3 to 4 centimeter wide right now. We take plugs from someone else and put it inside, the patients over there. This is osteochondral allograft. Allograft means somebody else over there. So allograft has been done for about almost 15, 20 years right now. They are good long-term, results right now. 25% failure for 12 years, which is not, operation only lasts for a year or two. So about 12-year data, 75% of people do well. They do have some conversion to a knee replacement, but these are big, big lesions over there. So in general, I tell people these are great operation over there. It's technically a little bit harder to do, but, it's very limited availability because you remember you have to take the cartilage from when they pass away, these cartilage has to be good. So these are probably younger people when they pass away, and they also have to kind of fit the contour because I could take it from the Marriott ballroom print over here. Well, it looks pretty good, but the pattern doesn't fit, the color doesn't match us over there. So sometimes the curvature doesn't match us over here. The operation doesn't work very well. So limited availability. You are robbing Peter to pay Paul, but Paul passed away in this case. So I think this would do that operation. So, the other patient, the other question the patient asked me is, are you kidding me over here? This is 2019 over here. You can't grow cartilage over here. We have Dolly. We clone the sheep right now in England. In China, you can actually have multiple monkeys that actually look exactly the same over there, clone that over there. You can't do it, right now. So there are some, success in terms of growing cells. So autologous chondrocyte implantation, or ACI, has been around since 1996. This is the first time we're actually able to kind of, grow people's cells. The reason why it's hard to grow cartilage cells, because cartilage cells, you remember I showed that picture, they're kind of not very social, cells. They kind of like to live on their own. Lots of extracellular matrix surround them. They're actually very picky. They're very picky in terms of growth, and they're also very slow growing. So very different from skin. You want a skin graft, I could take your skin, put in a lab. Within 3 or 4 days, big sheet of skin graft you could put on a burn patient right now. For cartilage, it takes weeks to grow, and they're very, very picky. Picky means if they don't have the right temperature, don't have the right pH, don't have the right steroids helping them, they just say, I don't want to form cartilage anymore. I'm just going to become like skin. So I think growing cells are hard. It took us a long time before we were able to do it. So Peterson, Lars Peterson was Sweden. That's actually the first one actually able to grow cells, and actually do a clinical trial, in 1997 over there, 1987, I'm sorry. The results are okay, so it was pretty exciting when this technology, came across. We're able to grow cells, put in patient's knee, but remember what we talk about is that, they're very picky. So we could grow the cells in the lab. They actually look like chondrocytes, but once you put it back in the patient's knee, the cell said, well, I don't want to form cartilage. I'm going to form scar tissue. So when they form scar tissue, it's no different from microfracture. So the first generation ACI, which is growing the cells and just kind of putting a little covering and squirt these cells back in the knee, didn't work very well. So this operation takes 2 operations to do, which is the first operation to do a biopsy, second operation to do the implantation. It's no different than microfracture. That's the one that you remember, we put little pokers in the knee, allow it to bleed into the knee itself. There's no difference at all. And also compare with Mosaicplasty results are not as good also. Now, there's second generation ACIs right now that's available in the United States about 2 years ago. It's what we call MACI, which is actually what they're able to kind of make a scaffold to allow you to kind of put the cells in the scaffold. So again, you remember we talked about the cell, they're very picky. Now we actually put it in an environment that allows it to grow better. And the scaffold is actually biocompatible, it's biodegradable, non-cytotoxic over there, and also stable graft to hold the cells. And the results are better. So this has been around in the United States since 2017 right now. It originally started in Spain and came over the technology. So results in Europe right now has been good. So 83% of these lesions are filled very well. Less than 10% failure in 5 years over there. But, it's still challenging. So when you look at this picture over here, this is a picture that had the MACI procedure done. It doesn't fill the same way. It can actually have a little bit of an indent still. So the hope is that the cells will grow and actually have that restore that, a depth of the cartilage. But time, will tell how good it is. It has been used extensively, mostly in Europe and in Australia. It's available in the United States about 2 years ago right now. Now, we do know that, some of these cell-based treatments are pretty exciting. I think that, it has been shown that if you do microfracture in the past, when you actually put little pokers in the bone, when you do cell-based, surgery afterwards, the results are not as good. So they actually advise them doing it as a first-stage operation if the bone is good. If the bone is not good, then the results are not as, great over there. It's not much difference when you do a smaller lesion. The small lesion, less than a centimeter, all the techniques are very similar. The bigger lesions, these ACI may be great. Well, guess how much this operation costs over here? $30,000. So it's kind of almost expensive as a car. So we use the tire analogy. This is not just tires. It's tires and the 4-wheel drive and the engine and the leather seats in there. So this is pretty expensive, treatment over there. It's $30,000. So insurance company doesn't really like to pay for this because, the efficacy has yet to be proven for long term over there. So the other thing that people ask me is, hey, doc, you could grow cells. Well, how about fetal stem cells? Isn't that great? That's like that's the buzzword, right? Anything young, juvenile is great, right? So people have also done that in terms of looking at juvenile cartilage. So these are actually cells harvested from actually young people that pass away, actually babies that pass away, and they actually mince up the cartilage and preserve some of the structure, and we can implant in the patient's knee. So these are all juvenile, particularly the cartilage, or de novo is actually the commercial name for that. It's been available for almost 13 years right now. The results are okay. The reason why there's not a lot of reports because the results are just okay. The reason why is that, remember, these cells are very picky. They're very slow growing. You put in someone's knee over there, even though you covered it in the area, the cells don't regenerate. So these are already mature cells, even though they come from a younger patient. They are already kind of formed. Once they form in the chondrocytes, if they have the extracellular matrix, they don't want to grow. So even though you mince it up, put it like an older patient's knee, they don't want to fill in a defect. They just stay there. So it's not, very, good long-term results out there. So I think that's, the state of the art right now in terms of cartilage preserving procedure. We actually have microfracture. We have, Mosaicplasty, osteochondral allograft and growing cells. So I'm going to ask the same question again. Let's see how much you guys retain. So I still have the same lesion. For 15 minutes ago, 1 centimeter lesion in the knee. It's still deep. It still involved the bone over there. What is the best treatment to take care of it? So again, the options are cleaning up surgery or shampoo, or conditioner. Also, you add that to it. Microfracture, little pokos, stimulate some healing, which is reparative. Mosaicplasty, Peter and Paul, same person, bring it around, move things around to make it work. Allograft taken from someone else, Marriott, Hyatt, to an Intercontinental Hotel over here. Growing cells or knee replacement. 1 centimeter lesion. What do you guys think? Yeah. Wow, good job over here. Even John is commenting on that. Good, great. So obviously no shampoo, okay? You know, the 5% over there, whoever the 5% over here must have hair, okay? So I have no hair, no shampooing, okay? Shampoo doesn't work, okay? So throw away shampoo operation over there. Mosaicplasty is probably the best treatment out there because it's a deeper lesion, a smaller lesion. Knee replacement is a bit aggressive for a 1 centimeter lesion. Just put things in perspective. You know, 1 centimeter is about the size of your kind of a ring finger, nail over there. I think there must be Dr. Ward hiding somewhere answering the questions for knee replacement over there. So we got to check him out. Chris, where'd you cross out his answer next time? So now I'm going to spend the last 10 minutes talking a little bit about what are other things we could do besides resurfacing. So the important thing, is us as clinicians to look at patients is that why? Why does it happen? Why does your cartilage, it get degenerated over there? So we actually have some treatment that we could do. The other thing you could say, well, why is it breaking down? Is it breaking down because of a traumatic, problem? You drove through a pothole. That's why, you actually have that injury. Or is it degenerative? I just drive the car a lot. I put 5 people in the car and 3 luggages in there. I just drive a lot. So if someone's overweight over there, or actually they really kind of abuses their knee, of course the cartilage is going to wear out more. Is it malalignment? Is it, hey, you know what? This car is just not tuned up very well. It's tilted to one side. Maybe that's why that's wearing out the joint over there. So that's something I want you to start thinking about it over there. And the other thing too, that when I do resurfacing for these patients over there, I still need to protect them. If normal cartilage get worn out, what makes my new cartilage not going to wear out, right? So I have to do something kind of correct that to restore some of the normal mechanics. So I use this, a picture over here. I think this is a picture of one of my athletic trainers' babies over there. You can when they stand up, right? Nice bow-legged, right? Steady gait, balance of it like a sumo wrestler over there. As we get older, our knees become straighter, and we're supposed to kind of restore our normal alignment over there. There's no normal, but we want it to be pretty straight. If you have a varus knee, which you call cowboy knee, which you kind of stand varus over there, which is the X-ray on the your right-hand side over there, you tend to wear the inside part of the knee joint more. Does it make sense? So when you send varus over there, I think that, Christy may have gone through it yesterday, the varus knee, you tend to wear out the inside part of the knee joint. If you're valgus knee, your knock knee, you tend to wear the outside, more. So when you start thinking about principles about the physics over there, hey, if I'm malaligned, doesn't matter what surgery you do over there, you're still going to break down the joint. So you have to correct some of the underlying problems over there. So this is what we could do. If you actually malaligned, we could do what we call high tibial osteotomy. If you have varus knees, I can make a cut in the tibia and actually wedge the bone open. So literally say, hey, almost analogy, say, I'm wearing out the driver's side of the tire. Why is that the case? Well, when you look at the alignment, there's, your car's tilted to one side. Of course, you're wearing that out more. Well, let me realign it over there to balance the car out over there. So these are what we call high tibial osteotomy to realign the leg. Same thing over here. If you have this gentleman over here, really, really, bad knock knee, no wonder they wear out the outside part joint more, right? So the forces just go more to the outside of there for you. So correcting the valgus, I think, is really helpful. Now, obviously, these are surgical correction. By the time they break down the joint, that's what we need to do. Now, a lot of times you may see these patients before they break down the joint. These are people that may be in their 20s or 30s coming, hey, my knee aches a little bit. And we look at them, well, how bad is it? Well, it's not too bad, but it aches a little bit on the inside when I run. And we look at them, oh my God, cowboy knees over there. You remember that talk over there? Well, let's actually, give you some braces to kind of knees straighten out more, or give them advice about shoe wear. So when you have a cowboy, leg over there, do you want high arches of your shoes or lower arches? So trick question over here. So if I'm cowboy knee, I'm standing like this over here with my foot standing on the outside over there. Do you want high arches or low arches? Low arches. Low arches, right? If you have flat foot over there, you make your knock knee. So when you actually have someone actually really high, varus knee over there, tell them to take the inserts out of the shoes. Or if someone comes in really, really knock knee, oh my God, go to the sporting store, get those inserts that help you out. I think it's good. So I think inserts doesn't help everybody. You have to see what works for them and what the problem is. And there's a simple thing you can actually, use in your practice over there. The other thing that I also want to tell people is about your patellofemoral joint, your kneecap joint. So a lot of times people come to see me, hey doc, my kneecap hurts over there. And then you get you see the personal trainer in the gym, or you may see a physical therapist, oh, your joints, your kneecap's malaligned, it's not tracking properly. So for me as a clinician, not tracking, probably means like a really medical diagnosis of telling people you have something that's wrong, but I don't know what it is, but it's not tracking very well over there. So not tracking very well usually means your kneecap sits on the outside part of your kneecap over there, outside part of your knee over there. So this patient over here on the top, on the right hand side, on the right knee over there, you can see how the kneecap kind of sits, tilted, and you're wearing out the outside part. Now, she's 40 years old right now. So by the time they get to this stage over there, there's not much I could do besides doing what we call realignment operation, realign that kneecap for them. Now the question is that can we make a difference when she was here? When she's younger over there, can we actually do some taping? Can we, change the way they walk over there to kind of help this? That's the magic question. I think there's a lot of research working on that right now. So if patient come in and see me with that worn out joint with bone-on-bone arthritis in the outside part of the kneecap, she's not ready for a knee replacement yet, but we could do what we call a realignment operation for them. I can actually bring the kneecap over and kind of balance that kneecap to almost like a re-tilting the kneecap to kind of sit in a better position for them. So these are some of the arthroscopic picture when I go in and kind of cut some of the ligaments, bring the kneecap over, and the bottom one is actually me cutting the bone where the kneecap attaches and bring it over to realign the kneecap for them. So this is actually what we call focusing osteotomy. That's when I actually really cut that, a kneecap, a kneecap attachment and bring it over to kind of realign the kneecap for them. So this can be helpful besides you need to do a knee replacement. So we don't always do just resurfacing. Sometimes we have to kind of look at why it happens. Do we need to realign the joint also? So, all right, I know that you guys are waiting for this over here. I'm going to give you like a 5-minute synopsis about, what about injections? So you guys say, wait a minute, all these surgeries are crazy. You cut the bones around over there. You kind of all these tires from moving back and forth. But what about injections? I want to know more about injections. So, steroids have been used for a long time right now. The steroids are, a good operation, cut down inflammation. We also know the steroids are not that powerful. It's not that long-lasting. It's kind of temporary effect to cut down inflammation, which is dealing with the pain. It doesn't really affect the degenerative process at all. Hyaluronic acid, there are multiple, different formats out there right now. The data out there are not so different compared with steroids, even though it's about 500 times more expensive. So I think a lot of organizations are kind of shying away from that. PRP, there's a lot more interest in that right now. There's some, bigger studies on PRP for osteoarthritis seem to have some benefit. The benefit is there. It's not huge. So we're still learning about this in terms of, who we could use in terms of, PRP and what are the benefits are, how to prepare for it. The problem with PRP is it's hard to compare with the studies because if I, take Colin's, blood out today, spin it down to the PRP, versus I take Colin's blood this afternoon after the donut, and then do a, PRP over there, it could be different over there. Or you could do my PRP like, now, and after like 3 hours when I'm really excited jumping up and down at the football game over there, my PRP levels could be completely different. So the PRP that we're actually giving patients right now is not very tightly regulated, so we don't really know what the effect is. So all these kit preparation, they have no clue what they put in patients' knee over there. So now the results are a little hard to interpret. Some results say no difference. Some results say some difference. Stem cell is interesting as an uncovered treatment, unpaid treatment at this point. People actually, use the buzzword stem cells all the time. We're fortunate at UCSF, we have a stem cell biologist, a Nobel Prize winner. He literally works 250 away from our clinic over here, Dr. Yamanaka. He can manipulate the cell. He would get any cells that's stem cell. He can make that cell go to particular, cell line lineage over there. But we cannot do it in this country right now clinically because of the regulatory process. So we cannot manipulate stem cell to tell them what to do at this point in this country because of some regulations. So whatever we do in terms of stem cells are not manipulated stem cells. You basically take the cells out and put it back to whatever joint or tendon it is and say, hey, cells, figure out what you want to do. Okay, so that's what I tell my 15-year-old at home. Figure out what you want to do. They don't know figure out what they do. The cells are not that smart over it. They can figure it out. If they figure out, they would have done it in the first place, right? So the cells are not that smart, but physicians are pretty smart, right? So there's a lot of these treatment done right now. There are tens of thousands of dollars, being done right now, and this is like $1 billion, industry right now. So I think there's a lot of, interest, in stem cell. There's not any science behind it at this point. And Yamanaka is probably laughing. He's like, you guys have no clue what you're talking about, but people are making a lot of money out of it. So there are some trials at clinical that UCSF doing right now. There are some trials we're looking at, particular molecules stop the degenerative pathway, which is called Wnt pathway. So basically, this in molecule we go into breakdown cartilage, degeneration, not rebuilding it, but just stopping the breakdown. So these are some exciting things that we work on right now. So, but it's clinical trial, which means that we don't know whether it works or not, but we're looking at possibilities. So hopefully, in the next few years, we can actually bring it to like clinical use for everybody to be exciting. So this is my level 5 evidence. So when you actually read articles or hear talks, you want to hear about evidence. What is the evidence, of this, on these studies? So this is my level 5 evidence, which is lower level. This is how I practice in terms of clinical when I deal with people with cartilage injury. If it's small injury, very, very small, well bordered on a younger patient, I do a microfracture. Anything that's deeper, lesion that involves the bone or younger active patient, I'll do a Mosaicplasty. Remember the bigger lesion, I can't do Mosaicplasty. Then I start to think about Allograft, which is taking it from someone else. If it's really, really big lesions over there, I may do what we call the cell-based treatment, which is take cells, and grow it and put it back in. It's pretty exciting, but it's pretty costly at this point. Don't forget the realignment, problem. Think about, sometimes when people come see you, about little things that could make a difference of them getting arthritis. So I'm going to stop here over here. Thank you for your attention, and I hope you enjoy the rest of the day. Thanks.